Hello, everyone. Good afternoon, good morning, good evening, depending on where you are joining us from. May I have confirmation if I'm audible enough?
Good afternoon from South Africa, Johannesburg. Yes, you are audible enough. Thank you.
Thank you very much.
Good afternoon from Lagos, Nigeria, Ibadan, Nigeria. Yes, you're audible enough.
Thank you very much. So I take it that I'm audible enough for everyone. So the rest of you can just, if you so wish, to introduce yourselves, you can do so in the chat box. But let me first of all welcome all of you to today's webinar. My name is Wisdom Akurugu, and I will be the moderator for this webinar. For the first time, we are organizing this webinar, and it's jointly organized by the Sickle Cell Disease Coordinating Center here in the University of Cape Town, South Africa. The center is funded by the National Heart, Lung, and Blood Institute of the US. The webinar is also jointly organized by the Human Health and Heredity in Africa Consortium, the African Society of Human Genetics, and the Wellcome Connecting Science. This webinar series aims to highlight ongoing research in data science and biomedical research, and to expose all of you who are attending to us today to cutting-edge methods and approaches in data science for biomedical and epidemiological research in Africa. These series of webinars are organized geared towards the 15th African Society of Human Genetics and the first Ugandan Society of Human Genetics and Bioinformatics Conference in February next year. Just as some housekeeping rules throughout this webinar, I would encourage you to utilize the chat box if you have any questions or comments while the presentation is going on. Please mute yourselves at all times and ensure that we all have a smooth presentation. At the end of the presentation, I will permit you to ask questions and also read those comments and questions on the chat box. Today's topic is the utility of polygenic risk scores and Mendelian randomization for chronic kidney disease in Africans. We are most grateful to have our speaker, Dr. Christopher Kintu, for making time to be with us and make his presentation. Let me introduce Dr. Kintu, who holds a degree in biochemistry and earned a master's degree in immunology and clinical microbiology from the University of Makerere. This year, he successfully defended his PhD thesis in bioinformatics, specializing in human genetics at the same Makerere University. He's currently a postdoctoral fellow at the Queen Mary University in London. His research focuses on polygenic prediction of traits and assessing causal relationships between traits. He's working on developing polygenic risk scores to predict kidney function, particularly estimated glomerular filtration rates in African population using African ancestry datasets. He's also investigating how lipid traits affect kidney function through Mendelian randomization and assessing reverse causation. Without much ado, please, let's welcome Chris. Chris, you may proceed to make your presentation.
Thank you so much, Wilson. And being here.
Have I lost you, or it's an issue from my side?
Sorry, I think I missed you there. Can you hear me now?
Yes, yes, loud and clear.
All right, so for purposes of introduction, I'll put my video on and then I'll get it off just to favor everyone. So thank you, Wilson, again for the introduction. My name is Christopher Kintu, and I'm based at Makerere right now, but I'll be moving for my postdoc maybe later this month or next month. And yeah, I'm here to present to you about polygenic risk scores and Mendelian randomization in kidney function. So I'm just going to share my screen now. Yeah, so again, welcome to this talk, everyone from wherever you are. It's afternoon here, and I'm glad that you made it for this first talk that's leading towards the African Society of African Society of Human Genetics in February, which will be held in Entebbe, Uganda. So you're most welcome, and you're welcome to Uganda next year. Here today, I'm majorly just going to focus on talking about how we utilize people's genetics, merge them into scores, and then we are able to predict how those genetics make them susceptible to chronic kidney disease, or how they contribute to kidney function in different aspects. And then also just find out what causes what between lipid traits and chronic kidney disease. Is it that someone first gets a malfunctional kidney before the lipid traits take on, or it's the other way around? So to do that, we use what we call Mendelian randomization, and that's the core of this topic. And so what is CKD? Normally, we determine CKD when someone's glomerular filtration rate is less than 60 mL per minute. Or, for example, if you have a damaged kidney and it has been persistent for about 3 months. And why should we care? We should care because currently that prevalence of chronic kidney disease in Africa is it's double digits here, like you can see in this map. And I always say, you compare this to an HIV map, and it's just going to be a single digit. But we also even now 16.5% up here. So this really needs attention, and we are not giving it the attention that it deserves. And that motivated this kind of study, which was part of my PhD. One other thing about CKD is it is a polygenic trait. That means that it's contributed to by more than one gene. And if you're going to determine the effect of someone's genetics towards its causation, then you need to add up each of those genetic effects together into a score. So that is what we call a polygenic risk score. So what we add up are called risk alleles. And each of us has those risk alleles towards a certain trait. And that is based on the genetics, the genes that we inherited from our parents. So it's a basic calculation. You just sum up an effect allele for someone into one score, and then that PRS. And after that, you put it into a population scale, a population level, and you're able to know where someone falls within a population. So is that cool? Yeah, that is really cool. But there is always a but towards genetics. And here, I'm just highlighting a few good things about polygenic risk scoring. It can enable us stratify people for risk to a trait at birth, like the first, yes, like that highlighted one. Or we could determine early symptoms or support diagnosis, treatment decision-making. So all of this usually leads towards what we call individualized medicine or precision medicine, which is the way to go. And this has been advanced for many traits like breast cancer, BMI, but it's not yet that much known for chronic kidney disease or kidney function. And so this is why we asked the question, what can we do? And what will that help us to do? Just like any other risk, just like any other polygenic risk score, say for breast cancer, you have a population, large population, and then based on the score for each person, each individual, you're able to group them into those ones that are high risk, the ones in red on one arm, and then those that are at least at minimal risk, the ones in green. But most of us will lie in this middle part. So usually, so you can see that this is a normally distributed population. And from there now, the outcome is we are able to tell which intervention, or you're able to advise clinicians in the long run, which intervention each individual needs based on their genetics. So for example, those at minimal risk will only need a standard intervention if they are living a healthy lifestyle. But then those at the extreme end who are living a sedentary lifestyle or alcohol, no, those of information from this. This is to give the clinical utility of all this work that we are doing about PRSs. That is the end game here. But to do that, Wilson, I request that in case I break, just let me know.
That's right.
All right. Yeah, thank you. But and where do we get that from? We get that from what we call genome data set studies. And most people here will appreciate that these are hugely expensive studies. And it's a no-brainer that most of them now, most of the data that we have is in the high-income countries because they can afford to do the studies. But what does that mean? Because of the inherent differences in genetic makeup between different ancestries. It could be between European, Asian, and African ancestries. We can't correctly have this picture if we use European ancestry to categorize Africans here. So it will be a bit messy. It will not be as accurate as this. And that is why now we said, okay, why can't we just leverage the little African data sets that are out there, and then we craft something that can tell us, that can help us stratify people according to kidney function based on estimated glomerular filtration rate. So to do that, we undertook 3 studies. One was just to assess how much data do we have or can we get from out there? And then we put it into one data set. So that was by performing a meta-analysis. So we went to different biobanks that I'm going to show, and then we merged all those 3 big data sets of Africans who had the kidney function phenotype into one, and then we determined some loci or novel loci from that. But then the whole issue about that was this was supposed to lead to calculated PRS that could predict CKD in continental Africans. So then the third study was a Mendelian randomization study, because of course lipids, someone's lipids should affect the function, the kidney function innately. So we wanted to see, based on the data sets that we had, where is this direction of causality? So we used MR to infer causal inference, to determine causal inference between lipid traits and kidney function based on estimated glomerular filtration rate. And yes, so the data sets and cohorts that we needed, one was the Million Veteran Program, which is a cohort based in the US. It's for US veterans. And this actually contributed the biggest number of individuals to our studies. And then the other one is the CKD Gen Consortium, which is also a collaboration between different groups, but majorly focused on chronic kidney disease. Then also the UK Biobank. So all these studies, all these cohorts, sorry, are major European cohorts, but we just looked out for the Africans within them that had kidney function phenotype of EGFR, or estimated glomerular filtration rate. And then that is all we picked and put together. But then we are also supposed to perform a polygenic risk score, which we needed to test in actual continental Africans. So we needed data from Uganda. We used data from Uganda, which is available in my research group. So that's the Uganda genome resource. And that was about 6,407 individuals. So this data set is majorly for Ugandans from southwestern Uganda, from about 28 villages in Chamliwa. And just to put numbers to each data set. So UKB had 6,217 individuals that had kidney functional phenotype of EGFR based on serum creatinine. CKD-GEN had 16,474, and the biggest, like I said, was MVP with over 57 individuals, and that totaled to about 8,027 individuals. And with that power, we were confident now to proceed to further downstream analysis. So overall, this is how this work moved. So one, we identified the cohorts. Some of them we had to apply for the data, like MVP. And then what we got from there were actually summary statistics. And we merged these summary statistics. So summary statistics come after you've done a GWAS. And it's like the result, it's just a small text file. Then we put them together using Metal. So we put them, we perform the meta-analysis. There are different ways, different algorithms that you can use to perform the meta-analysis. But here, we use the sample size weighted meta-analysis because of the different transformations within these cohorts for that particular phenotype. And then we leverage the biggest contributor to those three data sets, which is MVP, to now construct a PRS. So to construct a PRS, we used two methods. One is called the clamping and thresholding, which is embedded in PRECISE2. The other one is the Bayesian continuous shrinkage, which is within PRSCS tool. Then, of course, we tested it. We tested it in for transferability in continental Africans, and then performed the statistical analysis. The third study was purely determined by what was available in our arsenal. So we had the data sets for lipid traits, and we thought we could answer an important question. Do lipid traits really affect kidney function in Africans? And that brought us, now that brings us to the findings for the meta-analysis. Out of merging those big African ancestry data sets, we got quite a number of significant SNPs, 403. And when we clamped based on a 500 KB window because of LD, so we were left with only 8 lead SNPs. And from those 8 lead SNPs now, we started performing downstream analysis. For example, we checked against databases just to see what is existent right now in GTEx portal, in all those databases. Have they been reported to be associated with chronic kidney disease or EGFR at all in Africans? And indeed, 7 of them were, and only 1 was not yet reported to be associated with kidney function in Africans. And we call that our novel SNP here. And indeed, we mapped it back to its gene, and it was mapped to the ELN gene, which is an elastin gene that has functionality in synthesis of connective tissue. So, of course, that was exciting to find a novel SNP that's unique to Africans. And we also further categorized, mapped all the other lead SNPs to see which one was more strongly associated or had been reported to be associated with kidney function. And we see that 2 of those variants out of the 8 were mapped to previously reported kidney function loci, like HBB and LC22A. So CLC22A2 is a cationic transporter, and it has already been reported. Mark my word, not just in Africans, it has been reported in other ancestries, and it's mapped to kidney function. So it was exciting that even with this merged data for only Africans, we still had a variant that mapped to that particular loci. The same goes for HBB. HBB was actually reported by one of the studies from our group that it's already associated to EGFR. So we replicated it here, and that was really interesting. So HBB is a beta globin, which is a subunit of hemoglobin. And that's the heat map, the Manhattan, from that analysis. Then from genes, of course, we go to tissues. We want to see are these tissues actually, do they have any relevance with regards to the kidney? And when we mapped them to the tissues here, we see that it's not surprising, of course, that the organic the exchange cationic transporter is within the kidney medulla, and it's highly expressed here. And for HBB, like you would expect, should be highly expressed in whole blood, and that also showed in this analysis. And it's minimally expressed in the kidney function. So all this was just to further characterize and pinpoint the importance of these new lead SNPs that we had found that are uniquely associated to chronic kidney disease or kidney function in Africans. Then just a little more light about this novel variant, which had not yet been associated to EGFR whatsoever. It's mapped the ELN gene, and like I already said, it encodes a protein called tropelastin. And this has functions in forming the elastin protein, which is a major component of connective tissue. And so then out of those lead SNPs, the 8 ones, we further fine map. So fine mapping is, we want to really be sure which of these 8 SNPs is actually, which of these 8 SNPs is actually causal. So here we are ascertaining causality, but this is based on a 99% probability that you're sure that that credible set size is the one causing the changes that you're seeing in EGFR. But to do that, we use 2 data sets, one African and one European. So we use the Bayesian fine mapping approach. And for this one, the less the number of credible sets, the higher your confidence that that SNP is actually causally associated with whatever you're testing. And here I say that for these 2 SNPs, they are most likely causal. Why? Because in Africans, we just have one, like they're the only ones that were mapped that have a 99% credible set size of being causal. But in Europeans, we see that there are 53 others within the same region and 18 others that could be causal. So of course, you could also be right to also take the ones that are just 2, because 2 is still a small number. But for purposes of this presentation, I highlighted the first ones, the ones that had only a single credible set size. So to conclude that first part, we identified 8 EGFR variants unique to individuals of African ancestry. And one of those lead SNPs is novel in the African individuals. And Bayesian fine mapping analysis enabled us to identify 2 lead SNPs that we concluded were causal. Overall, these findings enabled us to uncover potential new locus for EGFR in African ancestry individuals. This work was published last year in BMC Genomics. Then now, having identified the data sets and even come up with a new loci, we were now more confident to proceed to the polygenic risk scoring part. But how do we exactly calculate this so-called polygenic risk score? So it's a base calculation. One, the only way we could, we all have variants that are set to a particular trait, and these are located within a certain genomic loci. And how we identify those variants is through SNPs, single nucleotide polymorphisms. But we can only have 2 alleles because we are mammals, we are biallelic. So you can only have 2 causal alleles. And that is what the G here stands for, the genetic dosage. How many causal alleles do you have? So you can have 0, 1, or 2. But then also for each variant here, it should have an effect. So it's either measured as a beta or an odds ratio. So the beta, that depends on the classification of trait that you're looking at. So when it's a beta, it's like a continuous trait. For example, what I was looking at, EGFR, but it could also be height. And then this G can only have values of 0, 1, and 2, because you can only have up to 2 risk alleles. So once you multiply the effect for each variant by the dosage or the risk alleles of each individual at that point, so that way you get a PRS for that variant in that individual. And you do that now for the millions of variants that have been identified as GWAS are significant for that trait. So just to put that in context, let's take two individuals. Say you have this gentleman and this lady here, and then you've done the genome, the GWAS, and you have your variants in one file. You know which variants actually GWAS significant, which are on the left here. So basing on the reference panel, which is still also based on the ancestry, you know what is supposed to be a reference. In quotes, what is supposed to be normal for that person at that position, and then in that population, and then what is the effect? The one when there's a change, what will contribute to the effect such that you see a trait in that population. So once you have this information aside as your reference, now they genotype everyone. It's just to know exactly which alleles you have at each position, which is demarcated by that RSID. So here, we see that in the first individual, we have an AG. So this is just similar to what we would expect. So this person has one, the reference allele is A, which is what is expected. And then he also has one effect allele, which is a G. So the dosage for that person is 1 because he only has one effect allele. And this effect is what the effect of that variant in that population. And this doesn't change per individual. It's the same, like you already noticed. 0.19 here and 0.19 here. So you multiply these two based on this, So you multiply those two based on this equation, beta, which is the 0.19, and then times the 1, which is the dosage or the effect that that person has, and you get 0.19. So for these two, that means that for these two individuals at that position, since they have the same genotype, their score will be the same, 0.19. But if we take another different example, this the number 3. So we expect that the reference is C, the effect is T. So this first person has a double T. That means that they have two effect alleles. So it's just 1, 2. And then the effect is the same across. So this person is going to have 0.62 if you multiply these two. That is their score. And then this person is going to have 0 because they have no risk allele at all. They have only the genotypes, the reference. And then they will have 0 here. So at that position, this one is at a higher risk compared to this, to the lady. And then you do that for like millions of SNPs, and then you sum up for each individual. So here we see this one has 1.75, this is 0.32. So that means that this person, in this simple example, is at a higher risk of whatever they were calculating compared to this individual. So we do that. That is done for everyone. Of course, now you can't do that manually. That's why now we employed tools of PRECISE2 and PRSCS. Then that will enable you, based on each individual's score, you can just now aggregate them. Yeah, so I need to take time on this because I know it's a general audience. Then, so now what the tools underneath have been doing that basic calculation that I've been saying, and then now they map it out into a whole large data set. So it's always nice to compare the tools because they have different methods. In this work, we used one that does clamping and thresholding, which is PRECISE2, and then another that does continuous shrinkage of betas, which is PRSCS. And at the end of the day, we will need to see how much does the genetics explain towards what we are, the changes we are seeing in kidney function based on EGFR. And that is calculated based on what we call an R-squared value, which is in here highlighted. So if you change this to a percentage, you see that this PRCS actually explained a higher percentage of EGFR, which is about 42% compared to 0.22% for PRECISE2. So this is actually almost doubled, which is a good thing. So that means that we can, the highest we can attribute to genetics in our Ugandans here is only 0.42%. So the highest you can go in percentage, the last I checked, is 100%. And 100% minus 0.42 is a very huge difference. So what does that mean? It means that as fancy as the genetics looks, it is still explaining the very little in the differences that we are seeing of kidney function based on EGFR. It's just 0.42%. So that means that there are so many other things that we didn't cater for in this analysis. So one of those could be environment, feeding, because when we are doing the analysis, we only catered for principal components, and sex and age. Only 3. So that means that the rest of the over 99% is explained by things that are not even genetic at all. So this means, this means there are some implications to this that we are going to see. So these are just the graphical representations of what we saw. We see that precise 2, or the Bayesian shrinkage, actually almost doubles clamping and thresholding. But also an important thing here to note is the sample sizes, because remember in the beginning, I told you we are grappling on the sample size. So, and this was shown because in this work that I just showed, we had the discovery cohort of about 58,000 individuals. But then we had previously in our group calculated the PRS for EGFR. By then we could only access 7,000 individuals. And we see that when we increase the discovery, it actually over doubled the previous one, just 7,000. Maybe some other people could try increasing the data sets, and then we see what comes out of that. But for now, all we could explain at that point was 0.42% variance in EGFR. Okay, then well, we also just try to see, not to take literature for its word, we just try to tease out if we have a discovery cohort of Africans, and then we test it in Africans. We already saw if we are to use precise, we can only explain 0.22% variance in estimated glomerular filtration rate. But then, what if we use a discovery cohort of Europeans, develop the PRS in European population, and then test in continental Africa? It was just, it's explained a much lower variance. And in fact, it was not a significantly associated PRS, as we can see here, it's about 0.05. And so to conclude with that, we computed the PRS of EGFR based on serum creatinine by leveraging a large discovery cohort of African ancestry individuals. And we further highlighted the differences in precision based, in prediction based on trace of method for developing the PRS. And here we also demonstrate that if we increase the numbers in underrepresented populations, we can make stronger predictions for EGFR in future. And so in totality, what could such PRSs do? These and other traits, they could enable us to find risk estimates using traditional risks, and also rare and rare genetic markers, like the BRCA1/2 mutations in cancer and HLA types in HLA alleles in type 1 diabetes. We could alter screening regimens and for different risk groups, and then we could also, the clinicians could, based on that, to encourage healthier lifestyles to lower risk, because in the beginning I showed that. And then also an important point is the precision of individualized medicine that could come out of these polygenic risk scores, because right now it's a one drug fits all, like, but if we respond differently to drugs based on our underlying genetics. So what if we could actually first know someone's genotype before we give them the medicine, such that they better respond to that? So this is like the future, or the main goal. This work is still under review in international reports. We are making a few changes and adding some new methodologies, but basically most of it is the same. And then finally, we now went through the Mendelian randomization. So what is Mendelian randomization? In a very basic, based on genetic, what drives which effect in what? And when I say what, I mean traits. So for example, is it that always when someone has, say, high BMI, you expect that they will have issues, or they will have hypertension, something like that. So observation studies, of course, do over time, but then confounding and also reverse causation. Reverse causation, for example, times would think that it is one trait driving to another, but then in reality, it is the outcome that is causing the exposure. So that's what Mendelian randomization does. So you have an exposure and an outcome. So by exposure is like a trait. So we have lipids and kidney function, and then we have genetic variants. So what we do is select these genetic variants, which have the genetic information that we need based on assumptions, like when you're doing 2-sample MR like we did here. So the first assumption is the relevancy. Are they actually relevant in terms of significance to the exposure? Are they significantly associated with that exposure? And that is usually based on the GWAS. So that's like the first assumption. And then there should be no confounders at all that affects the exclusion restriction assumption. So, because we know that the variants actually affect, they have different pathways, really. So they could affect this outcome and reach here. But then we only want to see if will they only go through the exposure to affect this outcome. So we also eliminate variants that will affect the outcome through different pathways. So in brief, this is what MR does. And testing all these assumptions is what we call data harmonization, which is beyond the scope of today's talk. So but what does that mean? It still means you've seen genetic variants, they come from somewhere, right? They come from GWASs. And still, all the associations or all the causal inferences that are now available mostly can only be, that direction of causality can be in one population or in one ancestry, sorry. So like this study, which also looked at the causal effects of serum lipids on kidney function, and it was a multivariable and bidirectional, but it was hugely European. So it was actually a European study. So still, we have the sample selection bias problem is still continuing, even in downstream analysis, or sorry, in downstream studies. And that's why now we came up with this idea that what if we just get our own data sets or lipids, the ones that we had access to, like the APCDR and Avigen, and then we determine how these lipids in these data sets are affecting kidney function in the MVP. So these cohorts are from the African continent, and we call them MALG. And the MVP is for majorly African Americans. So our MR scheme was as below. We have our exposure, like I said, in the fast forward direction. Our exposure was these lipid traits, HDL, LDL, TC, and TG. And then we first needed to see how does each of them independently affect EGFR. Does it increase the EGFR? Does it lower the EGFR? Remember, a high EGFR is good for kidney function, and a low EGFR is not good for kidney function. And then because they are lipid traits, most of them will share pathways. So we also merge them together. And then just saw the effect when you put all those genetic instruments together, what comes out of that, while throwing out total cholesterol, which is pleiotropic, some of them. So EGFR also affect HDL, LDL, TC, and TG. So that's the reverse correlation that I talked about. Now, after doing that and taking care of the weak instruments, horizontal pleiotropy, and all the data harmonization, this is what we found now. So we see that LDL actually is causal. It's causal associated with EGFR. But surprisingly, because we know LDL is usually termed bad cholesterol, here it's on the right. So what is on the right means that it's increasing the effect. That means that it's 1 SD, it is increasing EGFR. And shouldn't be like that. Okay, at least as we know biologically now, it shouldn't. And we decided to run the MR, but while eliminating total cholesterol from the analysis, because cholesterol. We still saw that LDL as a standout, and it is on the right. It's suggesting to increase, to be good for kidney functionality based on EGFR. Probably it could also be the cutoff levels for measurement of EGFR. I talked to a nephrologist who could suggest that between Africans and Europeans, but yes, there's still room for the explanations on that. Then the reverse association actually showed that kidney function will not have a reverse effect, will not be causally associated with lipid traits. So to conclude with that, these findings supported a causal association between lipid traits and kidney function and in continental Africans, but due to the unexpected, yes, that future investigations can open way to new findings, or they can just confirm what we did. Then future studies with bigger sample size and individual level data, because individual level data can enable us actually perform one sample MR also. Then we can confirm the true causality between serum lipids and kidney function. But then also this brings caution to the generalizability of findings from one population. This was also published last year in e-biomedicine group of Lancet. And so the general deductions, as I conclude with this, the general deductions by leveraging an African ancestry, we had new variants associated with EGFR signic to Africans. We developed a polygenic score that can better explain variants in EGFR. And then we genetically proxy LDL cholesterol might have a positive effect on. So, like I said earlier, this was part of from our group, the African Computational Group, as shown there. And some of this work has majorly been presented in Africa, and some are outside Africa. This is my supervisory team, and I always thank Professor Fatima Shagun for taking lead on this, and Dr. Tinashe Achikowore. So these are the organizations that contributed to the work, and finally, this you already know. I invite you to the 15th AFSG in Uganda next year. Thank you for listening.
All right, thank you very much, Chris, for this very wonderful presentation, quite informative. So as I indicated earlier, we will now take questions. If you have any questions, you can put up your hand and then I will permit you. Whether it's a question or comments, please, you're welcome. I think I already have some 2 comments from the chat box. One from Gerald, and he's saying, great work. Chris, you mentioned that increasing the population in the data set can improve performance. But don't you think that in addition to using Mendelian randomization, a smaller sample size that includes both PRS and MRS data might be a better solution for this? Chris, your comments. Chris?
Sorry, I was mute. Yeah, so yes, so Gerard says I mentioned increasing population and improve performance, but in addition to using MR, something that both and MR might be a better solution. Yes, thank you so much. Thank you so much, Gerard. Yes, indeed, that I agree with that, because we're also trying out a concept called polygenic MR. So that way we just look at PRS, variants that have been used to calculate polygenic risk scores in a trait, say from PGS catalog, and then we aggregate them together and then check their performance such that we eliminate the whole sample size issue. And so far it's working out well. So far it's working out well, and I agree with that. Yeah, but by the time this work was planned, this was like what, 3 years ago. That had not taken a good toll. So, but yes, I agree. And yes, there are also some people who are doing methylation risk scores. I'm not yet so conversant with that, but I'm sure, yeah, there's good stuff coming up. Yeah, thank you.
All right, thanks. I don't see any hand up yet, but there are other questions. Jen says, I'm very surprised, even with fine mapping, that we keep SNPs with so low frequencies. I don't think so. Such results with so low minor allele frequencies on chromosome 11 are relevant with fine mapping. All looks like it is close to RS334 and HBB very close, very well described. It looks more appropriate. Maybe if you have some comments on that, Chris.
Yeah. Question, Jean Tristan. So yes, I agree. It wouldn't be advisable to actually keep those with very low minor allele frequency, but I mean sometimes in the analysis you kind of because remember we came from 400 SNPs, got down to 8, and then we just had one that was novel. So out of those 8, unless you have another alternative, because sometimes actually people use proxy SNPs that are not actually within the data sets that they have analyzed. It was a matter of what is available now. After all that analysis, what is available within the fine mapping. But yes, you're right, we couldn't, it's not advisable to keep those with very low minor allele frequency in that population. Yes. But so like, for example, the novel SNP that we had, the RS774, when we were publishing, they asked us to replicate it in the Uganda Genome Resource because it was just in the MVP, it was just in non-continental Africans. So it was not there, it wasn't in the Uganda Genome Resource. So we had to show that at least we can use a proxy to replicate it. I didn't show those results. So yes, sometimes it's just about what I've used wrote down to. Yeah, but thank you for that.
Great. Akimulu wants to know how was the standardization of EGFR established given the fluctuations in creatinine?
Yes, thank you for that question. So standardization of EGFR, it's usually because creatinine is not directly measured in the clinic. So most times we base on equations, mathematical equations, and those have come a long way. They always right now I think the training one is called CKD-EPI, CKD epidemiology equation, which we use to calculate the creatinine. So does it fluctuate in the clinic? Yes. Are trying to use SADaCC, but since all those MVP, CKD, MVP, UKB, and CKD use the same CKD equation, we kind of based on that to take it as a standard to now merge these data sets together. I hope I answered your question. But the beta marker would be SADaCC. But one of the PhD students in our group already did that work, and it's published. Where he was saying, okay, look, now since creatinine is unstable, it's affected by muscle mass, age, and all that, and the equation doesn't put into account everything. Let's also use SADaCC, which would be a better one, but someone else did that work. Yeah, but thanks for pointing that out.
All right, thanks very much. I still don't see some hands, but Ted wants to know, you developed a PRS that represents continental Africa. Africa is diverse, and he's not sure if your Ugandan samples represent continental Africa.
Yes, yeah, thank you so much for that. Yes, at some point, yeah, that was an overstretched conclusion. I agree, but in terms of I could just comment about the diversity of Africa. Still, one of in our group, someone did actually proved that same point you're saying, that if you develop a PRS in one group in Africa, it will not rightly predict in another group within Africa. And indeed, that is because of African diversity. So this PRS that we developed, that conclusion came from the fact that we're almost the first people try that way of get Africans outside Africa and then try it on people from within Africa. But yes, maybe probably we should change that to East Africa in future. Yeah, thank you for that.
Right. So proceeding further, just to inform you, there are these travel fellowship that are available for the upcoming conference, and the information is just put up there. But Michael wants to know, first of all, he's thanking you for the brilliant presentation and wants to know whether there are any clustering that within the samples that you checked, which could be explained by factors such as nutrition. On the clustering.
This
yeah.
What be explained by what? Whether
Explained by
okay, I can read it. So it's okay.
Yeah, nutrition.
Yes, thank you, Michael. So the data set that we used, the Uganda Genome Resource, was already classified based on PCs. It has its own cluster, which were published in that paper that I showed in the data sets. But for this particular work, that's not what we didn't tease that out. So we focused on the principal components, just for ancestry-based kind of clustering, not nutrition, and then age and sex. But lately, I think people are also moving into the effect of environment, and it's kind of what that's going to adjust for in future analysis. So, and diet. So probably that should be looked at by further studies.
Yeah, just a last one, or probably so, from Ted, if you can explain the clinical relevance of Mendelian randomization. What about the mediation analysis?
Yeah, so the clinical, yes, the clinical relevance of MR. Yes, thank you. That's a really good question. So in the long run, this has an impact on the clinical, on patient management in such a way that there are those classical diseases or traits that you can know that, okay, this, even from observation, should be able to cause this. But what of those that are not outright seen, you know? In terms of, I'm not a pharmacist, but what if this drug, what if you could use one stone to kill two birds? If you know the pathway, the genetic pathway of a trait that is following to cause another trait. I think the clinical relevance is mainly going to be in the pharmacological part of the science, where I'm not a huge expert. But for now, it's just good to know that it's just enables us to zero down that given all these, because genes affect different pathways in the system, so which is the actual one, which that this trait uses to affect this other trait in the same individual or in a population. Yes, but I think that gives room for discussion. Yeah, thank you.
All right, I do not see further questions or hands. Let me take the opportunity to thank you very much, Chris, for the presentation. And for me, there's a lot to take home, particularly the fact that you've been able to find map and come out with certain SNPs that can be used as PRS for this disease condition, and particularly that some of these SNPs were different from what we have in the European population. Again, this goes to emphasize the need for African-based research. Thanks very much for this information. So to wrap up, we have a number of information in the chat box about the upcoming conference. We still have the abstracts being accepted until the 30th of this month, and travel fellowships as well. This webinar series, we would like to get some feedback from you. And so we have here that I just put in a survey just to get some information from you as to how we can improve these webinars in the coming weeks and months before the conference. So if there's nothing from any of you, I would encourage you to complete the survey, and to thank all of you so much for taking the time to be with us today. And I hope to see you in our next webinar. Thank you all very much. And please do complete the survey for us.
Thank you so much. Bye.